You're going to sit here, yeah? That's what Cindy said. I'm not telling you what to do. That's Cindy. We're going to have you guys to go into, I'll go and introduce you as I get into this. Unless you don't really want to, you can just come up. You're just on stand. You just don't look at it. You sit there and look pretty, what you're doing. Apparently this is some kind of hazing situation. I think it's a joke.
Kristen, did you make these slides or did Cindy? I was glad you put the C in the first slide.
Oh, why? What? What? C.
The copy I have,
Didn't have basic.
it was basis.
She was probably.
But all right.
You're right there in the middle there. Right. One more. Yep. I have your guys' name in order, so I want to go down the. Don't throw me off. Sure. Yeah. Roberta's coming. And Pocoli, they're just checking the shot right now to make sure they can fit whoever's at the end in. And then are we ready? Is this some sort of hazing or something? That's what's happening. I think you should lead with that. Say we're just hazing. I'm joking.
Does it have a button?
You're awesome.
So don't make any animal noise you can.
Don't rescue me if I say something bad.
Are they good with Pocoli?
Yes.
Can he move
He's
back?
gonna turn it on. I don't.
Oh,
I'll
is he?
just double check.
Actually, we could probably stay there. Actually, you can stay there. That's fine. It will work. I'll just reverse mine. Okay, good. You can sit right here. Oh, I thought she was gonna. She's gonna sit on your lap. Roberta's also a middle child, so she's very free spirit. Good evening. Hi, guys. Oh, I wish my kids listened like you guys do. Just with good evening. My name's Kristen Bacher. I am a new board member to the ALGSA. And so they put the newbie up first, because apparently this is what they do. Hazing. As some of you know, if you've been to a past symposium, this isn't usually the setup that we have. This year we're going to kind of change it up a little bit. We are going to have some panelists this year, a lot of Q&A discussion, so it'll be a little bit different, but it's really exciting. So like I said, I'm on the board, and my daughter is 3 years old, and she was diagnosed at 6 weeks old. And we have some excellent panelists here, one being Dr. David Pocoli. Dr. Pocoli is chief of the Division of Pediatric Gastroenterology, Hepatology and Nutrition at the Children's Hospital of Philadelphia. and the Perelman School of Medicine at the University of Pennsylvania. He is also the director and the endowed professor chair of the, I should have read this before, Bisecker Liver Center of CHOP. Did I pronounce that correctly? Okay. He became interested in ALGS in the 1980s, and in 1997, Dr. Nancy Spinner, Dr. Ian Krantz, and collaborators discovered that mutations in JAG1 caused ALGS. They, together with Dr. Benita Kamath, Kathy Loomis, and 24 other physicians at CHOP, formed the Alagille Center at CHOP and have studied over 400 families with ALGS. In 2006, they discovered the mutations in Notch2 can also cause ALGS, and the Alagille faculty at CHOP have published over 60 papers and chapters on the diagnosis of the treatment of ALGS, and Dr. Piccoli has attended all 7 Alagille International Symposia, numerous regional symposia, and 20 ALGS annual picnics in Pennsylvania. Can we get a round of applause for Dr. Piccoli? Next, we have Laura James Beckham. And Dr. Laura James Beckham, is a family physician with OB and urgent care specialties. She is also the mother of a 22-year-old Brianna and 18-year-old Gavin, and the wife of Ed, all whom are here at the symposium. Maybe they can wave. Where's Ed? No. Oh. They're here. Brianna was born in 1984 with ALGS. She's had severe liver involvement, failure to thrive, significant nutritional issues, osteoporosis and fractures, vascular involvement, borderline renal and pancreatic involvement, and the foggy brain. Brianna received her liver transplant in 2011 with a procedural complication that is starting to be recognized and is occurring with higher frequency in children with vascular involvement. In February 2016, she underwent a fecal transplant for C. difficile infection as a complication of her medications, and Dr. James Beckham has shared this ongoing ALGS journey with her family for years, and she and her family are here to share their different perspectives and welcome you to approach any of them with your questions. So, Laura James Beckham. And last but surely not least is the lovely Roberta Smith, also an ALGSA board member. And Roberta Smith is a mother of 12-year-old twins, Claudia and Chloe, her ALGS warrior. And she's a nuclear medicine technologist by trade. And Roberta also works at ItWorks distributor and director of communications and outreach for the ALGSA. So they will be our panelists. So first I want to let you know about these little note takers in your packet. Oh, sorry. Roberta, get some applause. Hey, you didn't stand up for me earlier to give me a hug, so that's a little trade-off. Sorry. Okay, in your packets is this fun little note taker here. If you want to get those out, you can use them if you want to use them at this session or other sessions, but you can title your session name, kind of drop down some notes, and it's already nicely organized for you too, so you can use that. I also just want to take a quick moment for anyone here who's new to the symposium or newly diagnosed. I came to my first symposium just 2 years ago, and the first session was really overwhelming for me, and it was just a lot of information. And I just want to encourage you that everything that I'm going to say isn't necessarily your story, and this information is just power. This knowledge is power for you, because you may not need it right now or ever, but it's nice to jot down and have. And I just want you to feel okay with what we're giving you, that this isn't necessarily everything you're going to walk through, but we have to give it to you because you'll need it. So I just want to say that for anyone who maybe is just a little apprehensive. So let's start with ALGS Basics 101. So first, let me hit the slide here. All right. So whether your child's been diagnosed or you've been around ALGS for many years, you probably are bombarded with a lot of these words every day, probably a lot of times a day, and it's very confusing and overwhelming. It's a lot to take in, and sometimes you look at them and you think, where am I going to start? Actually, we should probably find out kind of where we're at with everyone. Where are our new diagnosed families? Who's within the first 3 years been, or last 3 years? Hands? Okay. How about our veterans? More than 5 years? There they are. They're so excited. All right. So we first also want to talk about who, didn't know to click that twice. Thank you, to Dr. Alagille. He's the one who actually found Alagille syndrome. It gets its name from him. He was a French pediatrician who first described it in 1969, and he cared deeply about children. One of his favorite sayings was, "A physician who attends to adults does not need to love his patients, while a pediatrician cannot care for his patients without loving them." And so we owe him a gigantic thank you for giving our disease a name and for all those research he conducted to help everyone with ALGS. As we know, for a lot of families who haven't had a diagnosis name, this is really amazing that we do. So, what is ALGS? Well, that's a great question. First, ALGS kids are the cutest kids ever, right? Yeah. Mine's the one in the pink headband, so she's extra cute, right? So ALGS, simply put, is a rare genetic disease caused by a mutation in the JAG1 gene, or the Notch2 gene in some cases, and it occurs in about 1 in every 70,000 births, and about 8,000 people worldwide are living with it. It affects all ages, ethnicities, and both sexes. Its symptoms vary widely, and it's totally unpredictable. You name an organ on the body, and it's probably affected by Alagille syndrome. You also probably have some DVDs there on your table. In that DVD, you will find that Nicolette, she describes her condition as liver disease, bone disease, heart disease, eye disease, kidney disease, and a whole bunch of other stuff. And it's complicated and challenging to diagnose, manage, and treat. And tomorrow we'll get into a whole lot of other details on how this can be managed, but we just kind of want to get started with, obviously, the basics tonight. And you guys are feel free, obviously, to take those DVDs. It's important to understand that ALGS is highly variable. So many people with ALGS have changes in the JAG1 or Notch2 gene, but what symptoms result and how severe those symptoms are differ very widely. You could say it's kind of like a roll of the dice because you just never know what to expect. And this is true even if the same gene mutation is present in several generations of a family. Okay. So one person might have heart abnormalities with no effects of the liver. Some might have liver effects and no heart abnormalities. It might be obvious that someone has ALGS because of their facial features, but not everyone has those either. And it might it might take a genetic test to show without a doubt that a person is affected, and everyone is unique in dealing with a lot of stuff. Liver disease. If someone with ALGS has liver disease, the liver might have a few bile ducts, or the bile ducts might be narrower than normal. The skin and eye whites might be yellow or jaundiced. A person with ALGS might itch 24/7, as we all know, and have xanthomas, bumps under the skin from fat deposits. And 50 to 90% of people with ALGS have growth failure or grow very slowly. And a liver transplant might be needed if the liver is severely diseased. So next would be heart disease. Oh, these slides are killing me. Most people with ALGS have some kind of heart problem, and most of them are related to pulmonary arteries that carry blood from the right side of the heart to the lungs. And these defects cause blood to kind of slosh around in the heart in unusual ways, and it can cause that heart murmur. The most common problem is narrowing of the pulmonary arteries, but there can be other problems like VSD, ASD, aortic stenosis, and trilogy of Fallot. Okay, kidney disease. There might be kidney problems with ALGS. The kidneys might be small, or one might be missing or located in the wrong place. And one kidney might be full of cysts and scar tissues, or the kidneys might be fused together in a horseshoe shape. In severe kidneys, they might not excrete acids into the urine, so they can be removed from the body. And this is called renal tubular acidosis, and it can contribute to poor growth in people with ALGS. Bone disease. A person with ALGS might have butterfly vertebrae in the spine that look like the flying butterflies in an x-ray, which might help diagnose. My daughter had that specific, which helped give a diagnosis. They might have vitamin D deficiency that can cause rickets, which disturbs with normal bone formation. And the disease also might cause a person to be shorter than normal. A person with ALGS might have frequent bone fractures from poor calcium intake or malabsorption or decreased physical activity. All right. ALGS might cause eye problems as well in the front chamber of the eye and the retina. Posterior embryotoxin is the most defect, but it doesn't cause medical problems. There might be changes in the color of the retina, even when someone with ALGS normal vitamin levels. Some people with ALGS also can have vision problems. And the ALGS face, that sweet face, look at how cute. A prominent forehead, a pointed chin that gives the face a triangular look is common in childhood, and the eyes usually are deep set in with a nose straight. As a person with ALGS gets older, their jaw can become more prominent. In ALGS, the pancreas might be affected, causing pancreatic insufficiency. This is where the pancreas does not make enough enzymes and acid buffers to digest food and neutralize stomach acid. So pancreatic insufficiency makes it difficult to absorb fat from the blood correctly, and the fat is excreted into the stool, and the body doesn't benefit from its nutrients, contributing to poor nutrition and stunted growth. We're almost there, guys. Blood vessels. With ALGS, there might be bleeding inside the skull or other bleeding concerns. Most of the time, the bleeding occurs spontaneously without any head trauma. It is impossible to predict if someone with ALGS may have a bleed. Other defects in the blood vessels might include aneurysm or dilation and stenosis or narrowing in other parts of the circulatory system. Okay, so if all of that wasn't enough, it also might affect the development with the inner ear. I know some of us have talked about the bone structure in the inner ear. So hearing might be impaired. Sometimes a person with ALGS might have mild delays in gross motor skills or mild intellectual disability, but diagnosing the disease early and treating it aggressively, particularly with vitamin supplementation, helps with avoiding this happening. We did it. So obviously that's a whirlwind. That's a really quick rundown of kind of all the things that can be affected. But that's why we're here. We're here to learn about it and get more into that and to learn how to kind of ride the wave of how sometimes those different things will come along and something new will come along, and we'll just be kind of going through that in different seasons during the Alagille ride. So let's just take a quick wrap-up presentation of who maybe got a little bit more information from this presentation. Please, one person tell me you got some. Yay! Oh, good. That's the point, is just to give you guys a little bit more, learn something new that maybe you haven't learned before. So now we're going to turn to our panelists. We've got a quick overview. They're going to be answering some questions that we have here, and then we'll turn to you guys. So be thinking of things maybe you've been wanting to ask Dr. Piccoli, some seasoned mothers, and maybe jot those down. And Cindy will have a microphone in the audience, and she can come bring a microphone to you, and you can ask a question. So first, let's start with Dr. Piccoli. Where's your microphone? Oh, he has it hidden. We should make this like a game show, and you win a prize if you answer it right. So we're going to be talking about the different effects on the body, from itching to growth and nutrition to treatment options. But tonight we're going to kind of focus on more what causes ALGS and why it varies so much from one person to the next, and how it changes over time in people who have it. So our goal is to give everyone kind of a basic understanding, and then we'll get into the nitty-gritty as we go into the weekend. So can you tell us briefly what JAG1 and Notch2 are, and how do they cause ALGS?
Great job. Thank you, by the way. Did you do a great job? Yeah. Okay, so JAG1 or JAGD1 and Notch are members of a signaling pathway. There are different ways that an embryo decides which cells are going to be the top, which cells are the bottom, what's going to be the heart, what's going to be the liver. And in these different communication sort of pathways, Notch signaling turns out to be one of the most important ones in human development. It's something that is involved in the development of everything from fruit flies, where it was discovered, to worms, other mammals, and so on. So jagged is a little bit like a key that's sitting on the surface of one cell, and Notch is a little bit like a lock that sits on a different cell. And when those two come together and they bind to each other, it tells the cell with the notch what it's going to do or what it's going to become. So it's a signaling pathway, and In the heart, it's very involved. When you look at sort of fetal hearts, you can see that this gene is very active early on in heart development. It's active in liver development and so on. So they're genes. They're genes that tell cells how to develop. And most of the things that are issues in Alagille syndrome are things that start in the fetal development time.
All right. Excuse me. Does everyone with ALGS have the same gene mutation?
So I think the striking thing about Alagille syndrome is that almost everyone doesn't have the same gene defect. So in the beginning, there are other diseases, if you think about them, like sickle cell disease. There are millions of people who have it. They all have the same mutation. Alpha-1 antitrypsin deficiency, which maybe was considered when your child was being diagnosed. Almost all of the people who have the disease have one mutation. In Alagille syndrome, it turned out it's a huge gene, and almost everyone has a different mutation from one family to another. So now that we've identified mutations in more than 1,000 people, the places where you go to get your genes tested will say, oh yeah, that's been reported, so that's a real gene. Or sometimes there's a letter change and they'll say, gee, no one's ever seen that before, so maybe that's not real, maybe it's not really Alagille syndrome. But it was striking in the beginning that almost every family that was identified with a mutation had a new mutation. And so it's extremely unlikely that anyone in this room has the same mutation as another family. But everyone in a family, if there are more than one person in that family who's affected, they all have exactly the same mutation.
That kind of, I guess, leads into the next question is the mutation inherited or is it new in the affected person?
So that's a good question, and I think when we started out, we had no idea the answer of this, and so we would do a lot of things with parents, even to the point sometimes of, not just blood testing, but there were some parents who even had liver biopsies to figure out if they might have it. Benita Kamath in our group did a study which really sort of answered this very precisely. Once you have the gene, you can then go and look at everyone else in the family. And so the first question that we asked was, if we knew a gene mutation in the child, we would look at both parents and say, do they have that same mutation or not? And it turns out that it's not quite 50-50, but it's about 50-50 that the child has a new mutation that's not present in the parents. So it's a little bit more than that. So a little bit more than half of children have a new mutation. And we all have new mutations that our parents didn't have, but almost every gene that we would have a mutation in is recessive. So if you have a mutation in the gene for cystic fibrosis, you won't have cystic fibrosis unless you have two mutations, one from each side. So the thing with Alagille syndrome and with dominant diseases is you only need to have one defective gene to have the full disease. So about 50-50.
ALGS is autosomal dominant. Am I pronouncing that autosomal? Okay, good. What does that mean?
So autosomal dominant means that if you have one gene mutation, one gene abnormality, you'll have the disease. Autosomal recessive means that you need to have two abnormalities in that gene, one from mother and one from father, in order to have the disease. So most diseases, and overwhelmingly most liver diseases, are autosomal recessive. So in this way, Alagille is unique, and the recessive diseases are almost always inherited from both parents. But dominant diseases are commonly a new mutation. And that's true not just for Alagille, but for other dominant diseases of other systems, because one gene break makes the disease, whereas things like cystic fibrosis, usually what happens is each parent is a silent carrier, and those two genes have to come together to make an affected child.
So we know there are genetic tests available for ALGS. My daughter had one and confirmed it, but do you think it's necessary to have genetic testing to confirm that someone has the disease?
Okay. So we do not believe that you have to do the gene testing to confirm the disease in a child who really looks typically like they have Alagille syndrome. So we've always believed that, well, for a long time, a gold standard was a liver doctor looked and said, you have this and this and this and this is going to be Alagille syndrome. And so that, was the way we did it for decades before the gene was discovered. Now that the gene has been, so in that period in the 90s and, the first part of this century, it was very hard to get your genes tested. Sometimes there are probably people in this room who had gene testing started and didn't get their result for, well, the people in the early 90s, they waited like a decade to get their results. But testing came back very slowly. So now testing is done commercially in all different places across the country. It's covered by almost all insurances. So the question is, what are the reasons to do it? So not everyone has full-blown Alagille syndrome. So we do Alagille testing on many patients who just have heart disease when they're born, and they don't even look like they have liver disease. There are people who have a gene abnormality, and they look 100% totally normal, but they could have a child who's severely affected. So that's useful to know. There have been times where a parent hasn't known that they have a gene defect, but when you test them and then you say you should check for this and this and this as an adult, then it turns out that that's important. It's important to know if you're a parent of a child who's been diagnosed, and perhaps both parents look like they don't have anything wrong with them, but it's entirely possible, and it's that almost 50-50, that one of them could carry a more silent gene in them, and then they could have a subsequent child who has, very significant heart disease or very significant liver disease or kidney or other things. So there are a lot of reasons why you should get tested, and now the testing is extremely accurate, comes back quickly, and you can use it for a number of different things to predict who might have things going on. And then it's a whole different talk, but if you know you do or don't carry a gene mutation as an adult, that has huge implications for if you want to do family planning and other things, knowing that gene mutation or the lack of gene mutation in adults will let you know, that you're not going to have a subsequent child with the same disease. Whereas in the old days, we would say, we know sometimes we just can't tell, and you could have another child with Alagille syndrome. So there were many families who said, we have enough at this point, we're not going to have another child, whereas now we can be much more precise about that. So we would say, get tested almost always.
I have a question. So for the 4 or 5% that are neither JAG1 nor NOTCH2,
Yeah.
how confident can a physician tell the parents that you don't have the mutation without knowing that it's one of those mystery 5%?
Yeah. So I'll repeat that. That's a great question. And that's one we have not given up on. So, in a while ago, you found 1, 2, 3, 4 families with this mutation, and that was like discovery. And then we got to the point where we could find mutations in 40%, and then 60%, and then 80%. And eventually, by doing all these different techniques, we got up to the mid-90s. And then we asked exactly that question, since not everyone so who's right more, the geneticist or the clinician? So we still fight about this. It's a friendly fight, but we certainly don't agree, and there are no geneticists in the room. So I maybe am the most geneticist in the room, and I'm not, so I'm not sticking up for them. So what we did was we took, and this was a paper that we had 240 families, and we went through them, and we said, okay, all these guys have jagged. These ones, let's go back and look at the charts. Or do they really have Alagille syndrome? And they did. And so in the mouse, to make Alagille syndrome, you need a jagged 1 mutation and you need a notch 2 mutation. And if you just have a jagged 1 mutation, the mouse doesn't have anything wrong with them. So something that's hugely important in humans is not that important in mice, even though our chromosomes kind of are pretty similar in general. So that's why we looked at notch 2 in humans, and we found notch 2 causing Alagille syndrome. But then we also found a lot of notch 2 mutations causing things that weren't like Alagille syndrome. And then there are notch 2 mutations that cause a disease that doesn't look anything like Alagille syndrome, and there are a lot of those, and notch 2 is huge. So now we still think that there are some defects in that notch pathway that are not regular jagged, are not notch, but they're still in that pathway. And we're not confident that if you have a clinical picture of Alagille and are negative by gene testing, we're not confident that you won't have a gene mutation. And we're probably most interested in those cases because that's where you look and you find something new and different. I said there's like a key in a lock, but actually this pathway is hugely complicated with a whole bunch of modifiers and different things that modulate the pathway. And there have been a number of diseases that are almost like Alagille syndrome, but not quite. There's a serious left-sided heart defect that's in this pathway. There are a couple of bone syndromes that are in this pathway. There are other things that we wouldn't clinically say are Alagille syndrome, but they have embryotoxin, they have butterfly vertebrae, they have heart defects, and they're in this pathway with different genes. So it's still open, and I think there's still science to be done, but we think that's down to sort of like 3% of the cases.
This kind of goes on to, is it important to have other family members genetic tested? I don't know if that, you kind of answered that.
We would say yes. The different manifestations in Alagille syndrome, kind of each one runs independently. So if we said, in the room, how many people have a child who has mostly heart disease and only a little liver, there would be people who raise their hand. How many people have mostly liver, nothing else? How many people have 2 of 6, and so on? So you can have children or adults who have almost nothing and yet have the mutation, but then that still has implications for like your kidneys or your vascular system, things that you would never think about and your doctor would never pick up. So we think that now that it is cheap and reliable, we think it's indicated, and we think that parents should definitely get tested, and then if one of the parents is positive, the other kids should get tested in the family, even if they're fine. You will know things that matter. You may not exactly want to know them, but they're there, and it's better to know than not to know.
Okay. Let's see. So for the parents on the panel, did you guys have genetic testing done, the formal genetic testing?
Yes.
You did?
Yeah, we were actually part of the earlier samples taken at a symposium like this, and we did get the results back, and it did play a part in our decision. And I think anecdotally, reading about people who had tried to do a partial liver donation for their child and finding out that they couldn't, while they were on the table, I think it's important to get genetically tested. But we were part of the research genetic testing, because 1994, and of course not coming to a symposium until a few years later. So that's when we were able to get that information. But if today, I would encourage everybody to have the information. So you can be prepared for whatever you want to decide to do, and you can be prepared for whether or not there's going to be complications in your adult life, because you may be walking around with something that's going to be something in your adult life.
Same with you, Roberta. Was Chloe tested?
We had Chloe tested, but we did not as a family do that.
Yeah.
And we are going to be doing that.
Okay. I was also going to ask, Emery was, formally genetically tested. Is it important too if you want to participate in any kind of research? I know we had to give a formal diagnosis, genetic formal diagnosis to participate in a trial. Is that something to consider as well, or?
Yeah, I don't know if that would be the biggest reason, and
We'll just-
almost all research in Alagille, the clinical picture was good enough.
Okay.
So,
Okay.
I think, as time has gone on, to be sure that you're precise about studies, it's kind of like, in terms of like a trump card, the genetics is more important. For a long time, the face was controversial. The eye finding is not really that frequent. So there were people where a liver doctor would say, yeah, you have Alagille syndrome, but you wouldn't quite meet the criteria. The fact that now we have the gene testing, you can just say, yeah, for sure. And there are a number of people, probably half the people who carry the mutation don't have enough clinical things to be called Alagille syndrome, even by a doctor who's seen 50 cases. So there are a lot of people who carry the mutation, but they might have an eye finding that your optometrist or your ophthalmologist would never tell you about. Who gets a chest X-ray, and a belly X-ray, and our radiologists even, they said, butterfly vertebrae, we see them from time to time. Doesn't matter. And it probably doesn't really matter, except if you're trying to make the diagnosis. So there are a number of people who carry a mutation, don't know it, and unless they have a child who's severely affected, it just goes by the wayside.
So you kind of touched on this a little bit, but why does ALGS vary so much from person to person?
Yeah, boy, I don't know if I touched on that, because that's
Did-
like the million-dollar question.
Is it?
So Nancy Spinner and her group right now has a big NIH-funded study where we're looking at families that have multiple people in the family who carry the mutation. And so we have one family where the first child died at cardiac surgery of tetralogy of Fallot with some other complications. No diagnosis was made. And then the second child had what we would call typical liver Alagille syndrome, first couple weeks of life, jaundice, thought maybe it was biliary atresia and so on. And she went on about a decade later to get a liver transplant. The third child was normal. The fourth child had Alagille syndrome, but it was very mild, wasn't really an issue in heart or liver, and she just did fine. And the father went on to have chronic kidney disease and night blindness, and it turned out that he had Alagille kidney disease as an adult and had 3 children with Alagille syndrome, but one was substantially heart, one was substantially liver, and one was fine. And they all had the same gene because they were all in the same family, the same mutation. So we're looking at this and trying to decide, are there other modifier genes? The first thing we looked at was Notch2, because that also, it's related in the mouse, it's related in the human, hasn't really turned out. And I think we really, really don't know the answer to this question. It's one of the big scientific questions. If it's not just the same gene, but the same gene defect, why do people look so differently? And then if you have a tiny mutation in that gene, or there are people in this room who are missing the entire gene, you still look the same. So we really, that's one of the multi-million-dollar questions.
So maybe for Roberta, maybe you could tell a little bit how ALGS has affected Chloe specifically for her.
Well, my daughter, I have twins that are 12. They're going to be 13 in November. One does have Alagille, one does not. So Chloe has severe liver disease. She has stage 2 chronic kidney disease. She has a mild pulmonary stenosis. We have some posterior embryotoxin. We have all the vitamin deficiencies and, of course, the itching from the liver. I would say we don't have much for her. The pulmonary stenosis is very mild. She also has a murmur, but we see a cardiologist once every 5 years, so that's not an issue. Although she has a severe liver and the chronic kidney disease, the things that affect her daily are the itching, as you guys know, I'm sure many of you. That's a struggle. And also her vitamin deficiencies affect things like her skin and her hair and those types of things. So we really are more of a self-care kind of, I raised her to really try to self-soothe as far as the itching. I think that once they reach a certain age, they can kind of figure out where they're at with the itching, figure out what kind of things help them. So like in her room, we have her set up with a carpet runner to itch her feet, and an ottoman that's canvas that she rubs on. We have little hand tools that she uses, like brushes. So those are the things that affect her daily. Of course, we go to the doctor, we get checks on her with her certain specialists, and she has to do the blood draws. And, for a long time she had fear of the pokes, and it was a struggle to hold her down. And I think a lot of us go through those phases. But it will get better as they get older. And they can finally tell you how they're feeling. And that's a blessing, because at 12, I now know how she feels with things that she couldn't even tell me when she was 8, and I'm holding her down to get something as simple as a blood draw. For us, it's simple. For them, it's scary. So that's how we're affected.
Dr. Pooley, we know ALGS affects each person differently, but are there any general things you can say about the progression of the disease as the person ages? Is there kind of a general?
Yeah, so Alagille syndrome is really complicated. I'm sure you would agree with that. Some things that are developmental defects, what you have at birth is what you're going to have at birth, and there are little changes, but not much. So if you have tetralogy of Fallot or the VSD or some of the bigger cardiac disease, coarctation of the aorta, things like that, those are embryologic. They're kind of written in stone, and they're present at birth. There are other things that could be present at birth, like cystic kidneys, or if you have a single kidney or an abnormal collecting system or so on. And then there are things that develop over time, and some of them get worse and then better, and some of them just get worse. And then there are things that are consequences of nutrition that don't have to be a part of Alagille syndrome. So aggressive vitamins plus a G-tube can get you away from many of the things that early in my career were sort of the worst things that we saw. But you can sort of override those because they're not genetically encoded, they're secondary. So it's really complicated. Some things are written in the code and present at birth, and some things are progressive, but definitely Alagille. And then there are some things that are consequences of the things that happen in Alagille that are growth, nutrition, and so on. So it's really a mixed bag, and no, each organ is not really related to the other organ. So that we have patients who are nearly purely brain vascular abnormalities. And they went all the way through the sequence, even having neurosurgery, before they were diagnosed with Alagille syndrome. We have a number of heart patients who were never diagnosed with Alagille syndrome until we started doing gene testing not because we thought they had Alagille syndrome, but because we said, okay, we're going to start doing everybody with this and everybody with this. So it's really quite variable, and you can really honestly say, not only is almost every mutation unique, but every patient is unique, and that's why I think it's so hard to write like a general care plan because everybody's so incredibly different.
So Laura, maybe you could answer this. Have the symptoms for your daughter changed as she's grown?
Well, yeah, it's a wave.
You want to explain that a little bit?
It's
Ride
complicated.
the wave.
Okay, so Brianna started off with major liver involvement. So she was classical, I guess, in her entire presentation, although they wanted to do the Kasai because they were sure it had to be biliary atresia. So that was classic too for then, and the itching and the failure to thrive and the poor eating, the problems with nutrition. But it changes. The blood draws. I mean, simple stuff. The blood draws are very, very difficult, and then you come to an understanding. Eating actually got better for us. It got a lot better when we addressed some of the deficiencies because certain minerals, when you're deficient in them, they affect your taste and how you're feeling. I know they're using more medications now than we had available. There's some research medications that are dealing both with the xanthoma and the itching, which are all products of this whole backup from the liver and the toxins. And my daughter swears that affected her taste. And post-transplant, she wrote a whole dissertation on the change in her ability to taste food. So it changes. It changes what you're dealing with. Your school-age child is hiding their medicine. Yeah, I took it, and you find all the vitamin K tablets underneath the chair. Your baby doesn't do that, So developmentally, children change. The disease goes along with that, and the process of dealing with it and how you cope with it and what challenges you have is part of the journey.
Okay. And kind of last question for you two moms here. What do you think your biggest concerns today are for them at the age that they're at?
I think right now my biggest concerns aren't any different for concerns you have for young adults at this point. For my daughter, the liver transplant has made a huge difference. I think we still have a lot of, I guess, my husband and I do worry a lot about how her heart is going to do, how's the pulmonary vasculature, if that is going to put too much pressure on the heart, and are we looking at heart failure issues in the future. But right now, we're just dealing with, okay, you're out on your own and you're 22. And I don't think that's any different than anybody else knows.
How about you, Roberta? How old is Chloe again?
12.
12.
This is a tough age because they're just starting to understand. I mean, I could tell Chloe till her face is blue that, her liver's diseased. At 12 now, they're doing their science and their body anatomy, and they're getting a bigger picture of the enormous scope of danger that Alagille is, complexity. I'm getting the tough questions. Am I going to need a transplant? Will I die? Those are tough questions. So now we're getting more to the questions I don't want to answer. And how do I answer those? That's tough. But we're also hitting middle school, and we got, it's the most critical times. You guys remember middle school, most critical times of your life. So we got a lot of, questions of how do I handle these kids teasing, and my teachers say my skin's dry. They're pulling some lotion out of their purse for me. How do we handle that? So it's more questioning and understanding and the level of understanding, and I have to be prepared for that, and that's tough as a parent to mentally be able to do that. I didn't have to worry about that stuff when they were little. I could say, you know, it's just a scab, let's put a Band-Aid on it. And now they're explaining the Band-Aids and they don't want to answer the questions other kids have. So it's a lot of that stuff. But also, they're now more aware of how people look at them. And they're also more concerned about hiding their itching. Chloe wants to hide it a little bit more from other kids, where elementary school she didn't care, and neither did the kids, you know. So now it's more developmental issues, and they're troopers. They really are. They bounce back, but it's harder, I think, than. It's a tough age. Would you agree? It's a tough age. Yes. Yeah, that's where we're at.
Thanks, guys. Well, now we get to turn it to you guys. If you've been kind of thinking of questions, we'd love to hear from you. Hands. Cindy would love to come find you. Anybody? You got Dr. Bacoli right here. Anybody? Nobody? Oh, yeah. We got a winner.
We got to take her.
It's a pretty bad question.
I like them.
Because I didn't catch everything you were saying. When you were introducing the panelist, the center panelist, I don't recall.
Laura?
Yes, Laura. You were saying something about, you mentioned something about, I'm hoping you can help me.
I'll help you. I'll help you.
Yeah, you mentioned something about where more and more they're discovering that
Oh, I know what you're talking about.
Oh, she got
Go
it.
ahead.
So when Brianna had her transplant, there is a procedure that they need to do to access a very large vein. And the procedure is done classically the procedure's done, I mean, I've done the procedure. You go for the vein underneath the clavicle, because it's a big vein. And that's what you need, because, you know, this is a big procedure and you need access. But it's what's called blind stick. You kind of know where it is and you got to go for it. Well, they can do this with ultrasound now, by the way. And they don't all do it. And partly it's because of traditionally, when you've been trained in a procedure and you do it well in that way that you were trained, it's often better in most procedures to continue to do it the way you were trained, okay? What happened is I was approached because, so what can happen is you can have the artery stuck, and this instead of the vein. And when the artery gets a big needle into it, it bleeds a lot, and it's a big, horrifying complication. And we all get like this, very uneasy about this. It's one of those things as a mom, you find out that 2 hours into the procedure, they haven't started the procedure, and they've come to tell you that as a mom, you said, you know, your head says, you have nearly killed my child, okay? It's a bad outcome. It happens that she's doing really well. They had this wonderful person come in and do this rescue thing on this process. But what was interesting is the procedure was done in 2011, and the fellow let me know that she would have used ultrasound. So there was these feelings that my daughter and I have about this whole process. But to bring to what I was alluding to was that I went and I told the person who did the procedure when she was taking my daughter back, and this is something I think is important as a parent, I said, this disease affects every single tube in her body, every vessel, everything. Please do everything that you can, because there aren't, and her veins are going to be hard to get. And Brianna says they didn't listen. So it's important that people listen. The vascular surgeon who saved my daughter's life, who put a stent, or saved the whole procedure, who put a stent, which is sort of into the artery, subclavian artery, let us know in her visit 2 weeks ago that the surgeons are requesting that all the ALGS children have their major lines, this big IV, put in by the radiologist and have it guided because they're seeing this happen too frequently. And that's why I put it in my bio, because this is kind of new and sort of people are recognizing these things. And one of the things about having a not very well understood syndrome is that everything is always new and it's being discovered. And sometimes you, despite the fact that you don't have a medical background and you feel like you don't know that much, you do know. The same vascular surgeon said, well, maybe I can just go ahead and replace this stent that I put in someday with her saphenous veins from her legs. And I said, do an ultrasound, then talk to me. And he came back and he looked very sad. And the tech thought I was crazy, okay? Thought I was crazy. Of course, she's young. She's going to have beautiful saphenous veins. What the heck? She has not beautiful saphenous veins. She has tortuous, skinny little nothingness and lots of peripheral extra veins supplying the blood flow to her legs to come back to her heart. You're not going to be able to harvest a vein from her leg to replace this stent. This stent has to stay open, okay? So it's when you think, oh, it's really hard. They always can't get a stick on my kid. Yeah, well, it's probably got tortuous veins, And you have to think about these things and keep asking about those. But I put it in there because it was interesting to me that when it happened, it was just an accident. And now they're thinking that maybe they should be more proactive in preventing the accident because our children are at higher risk for that accident.
Can I ask a question? I have a question. That was the procedure for her heart, so they
No,
okay.
that was a procedure. That's a routine. It's just a routine procedure whenever you have a big surgery. She was having a liver transplant.
Oh, it was preparing for the liver transplant.
Prepare for liver transplant.
Awesome. Does that answer your question? You got it? Okay. Anybody else have any questions? Nobody? Any subjects? Nothing? Okay. Do you guys have anything to add? Dr. McCauley, anything else?
You ready for tomorrow? Long day tomorrow.
Well, that lead us into, after this will be, like Cindy had mentioned, we'll have the life celebration out here. We'll have some of those breakout groups. And in the morning, we'll be meeting for breakfast at 7:30, actually over there in the Crystal Ballroom. And we thank you guys so much for tonight. And we'll all be around for the evening if you have any other questions. Oh, we got one. Yay.
You're talking about the vascular system, and that's been one of my concerns for my son. Is there a doctor that specializes? Because we have a heart doctor, we have a liver doctor, we have a kidney doctor, but for the vascular system, is that a specialty? Because we've had a problem finding a doctor to see him.
That's a great question.
The vasculature above the clavicles or below?
All over.
Yeah. So so there's not really sort of in pediatrics a vascular specialist, but your liver doctor will know about all the different arterial abnormalities, and they're mostly arterial abnormalities that happen either above or below. And the aboves are all neurology, neuroradiology, neurosurgery, but below, so if like one of the most common is a kidney artery narrowing. And many of these things can be seen, well, they can be seen by a couple of different techniques, but one is ultrasound. A better one in many ways is an MRI, and any place can do a really good, high-quality CT scan of that whole area. And I think, you know, people know what things might be there and they know what to look for. I mean, sometimes the narrowing of the biggest blood vessel, the aorta, we're surprised by. Sometimes you hear a murmur, but sometimes you don't. But it shows up on those kinds of imaging. And, you know, so for us, the radiologists are sort of from here to here, and the cardiologists are here, plus they look at all of these other blood vessels. And then we, because the neurovascular problems are silent, we recommend that sometime in late childhood, you get one MR blood vessel study. So it's a special kind of MRI of the neck and brain to see whether there are abnormalities there, because they're silent for a long time before something happens. But there's not exactly, each group kind of owns, the kidney people own that kidney artery, and, you know, but they're easy tests to do, and if they make sense based on the problems that you're having, the imaging is really high quality. It doesn't miss. But some of these things, when you're talking about what things progress, blood vessel narrowings can progress with age. And so things like the kidney artery narrowing, or narrowing in the artery that leads to the brain, can really progress over even years. And so something that's a little bit abnormal when you're younger has to be followed up.
Thank you.
Thanks.
So to follow up to that, who would you see to have this blood vessel study done? Like which doctor or type of doctor would order that? And my other question would be, if you have a child that has had the diagnosis and maybe only has, like for instance, our daughter only has heart or liver issues, are there other tests that we should do prophylactically that could help prevent problems from erupting later?
So we think that the neuroimaging is one of those things that should be done even when you don't have symptoms, and certainly if you do. If your child had high blood pressure, not portal hypertension, but high blood pressure, cuff blood pressure, very definitely you would do kidney artery ultrasounds, because that's one of the things that wouldn't be very common in other children, but is much more common in Alagille syndrome. We don't usually recommend search. So when a cardiologist does an echo, they usually look at the aorta, the top part of the aorta. So they would see a coarct, and they're usually the ones, if you have a mild coarct, they diagnose it. We don't usually recommend scanning between here and the hip for blood vessels in people who have no symptoms. But there are sometimes people who have an unusual takeoff of an artery or something else, or a double artery, things like that. Mostly they're not important unless they cause symptoms. Getting a second wind here.
I know,
Woo! I like it.
4 minutes, so yeah, let's go for it.
So I have a question about the itching. We were recently told that when my son goes through the hormone change, there's a possibility that it could go away or decrease significantly. And I had never heard that before. So have you seen that? And
Yeah, so that, I'm not sure that it's really puberty, but there are a large number of children whose ability to excrete bilirubin and bile salts and all the other things that need to be excreted gets better and better. So there are many children who, after the age of 2, 4, 6, the itching gets progressively better with time. The xanthomas go away. The liver becomes sort of more functional in its excretion. Usually, if it's going to happen all the way, it happens well before puberty. But it can clearly get better. We don't really have a way of predicting that. If we could predict who was going to get better, I mean, in our center, when we see kids who are brought in and they're 2 years old and they've had a recommendation for a transplant, we almost always say, try to hold out for a little bit and let's see which way this is going. Because there are many kids who were sent to us with the question of, we've been told we have to transplant, we need to go to transplant now, and some of those kids 15 years later are really good and not transplanted. And in transplant centers, so it probably half of the people in here were told that their child looked like they had biliary atresia right in the beginning. If you and there are a number of infants with Alagille syndrome who have the biliary atresia operation. But if you're 2 years old with biliary atresia and you have a bilirubin of 5, you're essentially 100% going to have to get transplanted. And if you have a 2-year-old with Alagille syndrome and your bilirubin is 5, you're actually very likely not ever to need a liver transplant or not to need one for 15 or 20 years. So it's a little bit, it depends. Alagille is so rare that the centers that do a modest number of transplants and don't see that many Alagille patients, as people say, and it's maybe not a good analogy, but if your tool is a hammer, every problem looks like a nail. So not every child who's a little bit jaundiced at age 2 or 3 needs to be transplanted. That's really true for Alagille syndrome because it's one of the diseases that can get better on its own.
Good.
My son was recently diagnosed with a small aneurysm, and I'm wondering if there's a direct connection with children with Alagille syndrome. And
Aneurysm in the brain?
mm-hmm.
Yes.
And is it a high percentage? Is it a higher risk in kids with Alagille syndrome?
It's a low percentage.
Okay.
It's a higher risk than baseline. And depending on where it is, this is one of the reasons that we do, studies even in people who don't have headaches or other symptoms, because there are times where either the neuroradiologist or the neurosurgeon can do something about this before it becomes life-threatening. So it is aneurysms and narrowings and absent vessels are all part of Alagille syndrome.
Okay. Is it a high percentage of children that has it, or?
It's a very low percentage of children with Alagille syndrome who have it,
Okay.
but it's extraordinarily important when they have it, and it's a tremendously higher than kids without Alagille syndrome.
Thank you.
So I have two questions, and the first is pretty quick. The narrowing of arteries, of blood vessels, aside from stenting and ballooning, are there any other therapies for coping with the stenosis?
So stenting, ballooning, cutting open, patching with another piece of tissue, cutting out the narrowing, or replacing. I think those are the options that you have. So it is more than just, sort of balloons and stents, but it depends which artery, where, how long is it, how much play do you have in between the two ends. It's like plumbing in some ways. You could cut out the bad piece of pipe, but can you really pull the other two pieces back together? So there are a lot of different options. And sometimes when you have a lot of different options, you know that no one of them is perfect for everything.
Second question. So it sounds as though you believe that whenever a child is suffering severe problems, liver problems, that it's best to wait and see whether the condition improves. I ask this question because I received the same advice, and I've come to believe that it was one of the worst decisions I made, that I wish that I had made the decision to transplant much sooner. The change was so dramatic as to be magical.
Yeah. So that's a great question. And so every child and every scenario is a little bit different. So it's different based on how abnormal, how much suffering, how high is the bilirubin, at what age are they, what are their other options. And, as time has gone on, transplant has become better and better. I mean, many of the kids are out of the hospital in 7 days. They're, doing things. We're using more living-related donors so that people can actually get a transplant and not wait for 2 years. I think there are a lot of people who, particularly the ones who, and we now have a transplant physician in the back in the corner, I think, so we might put him on the spot. Raise your hand really high. So he just walked in. I don't know if he heard this question. So when a transplant works, it is great. And transplant in Alagille syndrome and in general has gotten better and better over the last decade and certainly 2 decades. When it doesn't work well or it has problems, you take someone who was having issues and sometimes suffering, but you kind of transplant is trading one disease for another disease, and you hope that the one you put in works really great, but it doesn't work all the time. So there are some times where the advice is to go to transplant. Maybe it wasn't really so critical at that time, and then you have a transplant complication and something really terrible happens. I think we've all moved a little bit more towards transplant over time because transplant has gotten better and because we're doing more living related transplants, you can actually get a liver. Because a lot of times, and I think there'll be several sessions tomorrow about transplant with, directors of transplant services talking. But, some kids, although they're suffering, don't really get like a score. A score good enough to get a liver on the, kind of open, allocation market, the way things are. And then you sort of, there are people who are on the transplant list for incredibly long periods of time. If you can do a living related, you don't have to wait for that, allocation. You just have a relative, a friend, a clergy person who says, I'm going to give a little piece of my liver, and you can go forward. And I don't know how many people had living related donors in here. I think most of the people who were transplanted 10 years ago had to wait for a whole liver. The living relateds, I think, have changed the game a lot. But transplanting at age 2, it usually works out, but it doesn't always. If it works out great.
And do you have an age at which point you would tell parents not to hope for an improvement?
So we do a little bit, but it's defied numbers. So the older you are in the school age years with a really elevated bilirubin, even if your liver doesn't give out by age 10, you commonly will give out by age 20. And if you know that you can see the end of the liver, then it's really better to do a transplant now. There's no sense like, let's duke this out for 4 years and suffer and have all the consequences. And then when we're in worse shape, let's do a transplant. So we're trying to make those predictive sort of algorithms. We're not so good at that. And then there are many kids who look really suffering, doing badly. They get a diversion, and a diversion which is much less of an operation than a transplant, and then they are massively better with their own liver, and a diversion doesn't really have any of those immunosuppressive medications or anything else. So you'll meet a number of people who said the diversion was the best thing I ever did, and I don't need a transplant. Before the diversion really caught on, we commonly took those exact same kids and went to transplant, not diversion. But every child is different. I think, there have been people who have been transplanted for their bone disease, certainly for their itching, and then a number of patients with Alagille syndrome, the liver, after a period of time, turns into cirrhosis, liver failure, and that always has to be transplanted. So when you see that the albumin is dropping, the PT's climbing despite vitamin K, growth is not being supported, there's no sense pushing that liver because that liver is unlikely to be helpful to you 1 or 2 years later. But this is where it's very individual and it depends on a whole bunch of different things. And we tried to make it numeric, like the PELD score, where you could say, this liver, you're going to get this much more time out of it. It just hasn't worked.
Oh, one last question. Years ago, I was told that liver transplant would not improve failure to thrive, that the growth would not improve, the rate at which he was growing would not improve. Is that still the belief? Is that still the consensus? My experience...
Can I punt that one to you?
Well, I think the main concept is that you should not go to transplant thinking that if someone, depending upon where the person is in the growth chart, is what is going to be important. When we did a study back in UCLA, we showed that patients after transplant, their growth improved overall. When you compare them, when you did like a pair comparison against another patient with quite similar conditions. But we have to remember that there are reasons beyond the liver for a kid with Alagille to have failed to thrive. All depend upon heart conditions. Is there pulmonary hypertension, lung issues, or is there pancreatic insufficiency? I mean, there are other factors that can impact growth. We know that there are kids that may grow the same fashion and someone else that doesn't have Alagille syndrome, but we also know that kids with Alagille syndrome growth in a different pattern, and that's what Dr. Piccoli has developed with his group, those growth charts to follow those kids. But I think in general, when a kid really needs a transplant, as Dr. Piccoli mentioned, he is going to improve failing to thrive because you have, in that case, you will assume that the liver disease is a factor in that failure to thrive. But what we cannot, we have to be careful when we look at this and not to say that someone will have a normal growth chart just because he got a transplant. You have to look into all those other factors that are involved in a particular case.
So I think we have to wrap it up, but a couple of things. We will be going into transplant and diversion in a lot more depth in one of the deep dives tomorrow afternoon. Also, there'll be cardiac and vascular issues that we'll talk about in a breakout, and post-transplant issues for those who have already had a transplant but have questions about that. And then all day tomorrow, we're going to be going into lots of detail about all kinds of things about Alagille syndrome. So if you have questions that came up for yourself while you were sitting here listening, jot those down and you'll have an opportunity tomorrow to ask those. And I guess we're going to wrap this one up. We have the life celebration starting in about 15 minutes out here in the courtyard, and deep dives or chill and chats later this afternoon, or later this evening at 9:30. So enjoy and thank you very much. Let's give a round for our panelists again.